morning friends. Today we will be discussing a very common condition seen in neonates, jaundice, also called as hyperbilirubinemia or neonatal hyperbilirubinemia (NNH). By the end of the session, we aim to learn about what is NNH, about bilirubin metabolism, to understand the causes of NNH, the differences between the physiological and pathological jaundice, and finally the most important objective, how to approach and manage a case of NNH in a neonate. NNH is nothing but increased bilirubin in blood, causing increased bilirubin accumulation in the skin, which leads to yellowish discoloration of the baby called icterus. Now, to understand the etiology and the problems associated with NNH, we need to understand the metabolism of bilirubin itself. To make it simple, hemoglobin when gets metabolized forms bilirubin, which gets conjugated in the liver to get excreted in the gut. The conjugated bilirubin is excreted in stools as stercobilin. Some amount after the conjugation in the gut may again get absorbed in the blood. This is called as enterohepatic circulation. Now, as we can see, since all of us including neonates have hemoglobin, a normal neonate will also have some bilirubin, which is absolutely physiological and does not harm the baby. This is called as physiological jaundice. But due to some reason, if the bilirubin in the blood is increased, then it may harm the baby, as it enters the brain and causes neurological damage. This is called as pathological jaundice. What can be the causes of this increased bilirubin? If due to any reason more hemoglobin gets catabolized, example ABO or RH incompatibility, when more RBCs get lysed due to antibodies present in the blood, or there is polycythemia when there is more hemoglobin present in the blood, which results in more getting catabolized, or there may be extravasated blood accumulated somewhere, example cephalhematoma, which ultimately gets broken and more bilirubin is formed. A second category can be when there is impairment in the conjugation of the bilirubin in the liver. For example, preterm babies, when the capacity of the conjugation is itself limited due to prematurity, or other reasons like hypothyroidism, some metabolic disorders like Gilbert or Crigler-Najjar disorder. The third category would be when there is impaired excretion of the conjugated bilirubin from the liver into the gut. But the catch over here is that in blood, unconjugated bilirubin will be normal, but conjugated direct bilirubin will be increased. This is called as neonatal cholestasis, and in such cases, surgical causes like biliary atresia should be ruled out. The last category would be when due to some reason enterohepatic circulation is increased, which again leads to more bilirubin in the blood. This might be due to poor feeding or poor gut function. As I said, a baby might have physiological jaundice or pathological jaundice. So, how to differentiate between the two? Well, these are the factors when present indicate pathological jaundice. Also, whenever a baby requires treatment for any jaundice, it implies it is pathological. Now, how to approach a baby who looks yellow, that is a case of NNH. First, we need to assess the severity of jaundice to see whether it is physiological or pathological. Clinically, this can be done by using Kramer's scale. The concept of Kramer's scale is that dermal staining of the bilirubin progress in cephalocaudal progression. In this method, in the natural light, the color of skin is assessed after blanching, that is by pressing the skin with our thumb. The lower the skin, that is more caudal, where icterus can be appreciated, that is yellowish discoloration can be appreciated, the more the expected serum bilirubin level will be. This table gives the approximate bilirubin level. As we can see, if there is yellowish discoloration till palms and soles, that is zone 5, that means bilirubin will be very high, above 15 to 18 or maybe more than 20 milligram per deciliter, which is a medical emergency and needs immediate treatment. The second method of approximating the serum bilirubin level is by using transcutaneous bilirubinometer. This machine is pressed on the sternum and it gives the approximate serum bilirubin levels. Also, if there are any signs of brain damage like lethargy or irritability, hypertonia, abnormal posturing, shrill cry, seizures, etc., then it automatically implies that the serum bilirubin is very high. After clinically estimating the approx bilirubin level, and if we think that the bilirubin level may be in the pathological range, then we send the serum bilirubin levels in the lab. If the conjugated bilirubin is high, we work for neonatal cholestasis, which we will not be discussing in this session. But such babies should always be looked for clay colored stools and dark colored urine and worked up for the surgical causes. If the unconjugated bilirubin comes high, then we think of medical reasons. To know whether the baby requires treatment, we compare the serum level with the treatment threshold cutoff of AEP charts. For this, we need to assess the gestation age of the baby, the risk factors for brain damage, and postnatal day of life. We follow the lowermost, that is the high risk line, if gestation is 35 to 37 weeks and risk factors are present. The middle risk line is used when either gestation is more than or equal to 38 weeks with the presence of risk factors, or gestation is between 35 to 37 weeks with no risk factor. And follow the topmost low risk line if gestation is more than or equal to 38 weeks with no risk factors. After deciding which line to follow, we plot the bilirubin level according to age, that is postnatal day of life. If the bilirubin is below the cutoff, that is below the line, then phototherapy is not required. If the bilirubin level lies above the cutoff, that is above the line, then phototherapy is started. For babies below 35-week gestation, we use NICE guidelines where we have separate charts for each gestation. Treatment. Phototherapy is the mainstay of treatment and a very safe modality for treatment of these babies. This is an example of a baby under phototherapy. It acts by converting insoluble unconjugated bilirubin into soluble isomers that can be excreted in urine and stools. The precautions we need to take is that maximum possible area of skin should be exposed with eyes and genitalia covered. Baby should not get overheated. Photoirradiance of at least 30 microwatt per centimeter square per nanometer should be ensured in the wavelength of 460 to 490 nanometer. During phototherapy, hydration should be maintained and breastfeeding encouraged. Repeat serum bilirubin is generally measured after 12 to 24 hours. If the bilirubin is decreased to at least 2 to 3 mg per deciliter below the cutoff level, then phototherapy is stopped and baby is monitored for rebound hyperbilirubinemia. If the serum bilirubin level of the baby is very high, then we should similarly check for the exchange cutoff levels. And if the level is above the exchange cutoff, then DVET, that is double volume exchange transfusion, is done, where the whole blood of the baby is exchanged to rapidly decrease the bilirubin levels to prevent the brain damage from excessive high bilirubin. DVT is also done immediately if there are any signs of brain damage. Apart from phototherapy and DVT, there are some other modalities of treatment which can be used in NNH, depending upon the urgency of decreasing bilirubin levels and the experience of the healthcare provider. These act at different levels as shown. Now, after initiating the treatment if required, we search for the etiology of hyperbilirubinemia. We take the appropriate history, do the examination and send the required investigations. Lastly, the babies with very high bilirubin levels, especially more than 20 mg per deciliter, or the one requiring DVET, needs to be followed up for neurodevelopment impairment. Hearing assessment with BERA should be done to rule out hearing impairment due to high bilirubin. Take home messages. NNH is one of the most common neonatal problems encountered by doctors. A systemic and structured approach should be followed for the management of any neonate with NNH. In babies with conjugated hyperbilirubinemia with clay colored stools and dark colored urine, surgical causes should be ruled out. Any baby with yellowish palms and soles or any signs of brain damage is a medical emergency, and treatment should be started immediately. Phototherapy is the mainstay of treatment, and breastfeeding should be encouraged and ensured during phototherapy. Thank you.